Together talking a little bit about motor neuron disorders. And our focus will mainly be on lower motor neuron disorders because that is what we focused on in the lecture. But there is overlap in some disorders affecting both upper and motor neurons. So we will talk about, you can't completely figure out what upper motor neurons are. In this first part, we'll talk a little bit about principles that you can apply to occupational therapy intervention. And then at the very end, I'll come back to and talk about concepts of motor control and motor learning, which are things that you learned about in theory class. I think Al did those lectures for you. Does that ring a bell at all? Something like that happened. I'm pretty sure he's going to talk to you about them again. So we'll try and tie in a little bit about neuro with those theories, and then give you a fast forward on kind of how we're going to be integrating throughout these next 3 motor lectures stuff that's happening in those higher cortical areas and in like the basal ganglia and the cerebellum. So that's kind of our outline. Start with what motor neuron disorders are. So as the name sounds like, they are progressive neurological disorders that specifically target motor neurons. And again, some diseases target only upper motor neurons, some target both upper and lower motor neurons, and some will target both. And the clinical picture is going to look different depending on which type of motor neuron is affected. So if you are doing a clinical evaluation, you will look at some things like reflexes, muscle tone, atrophy, and to help you determine what is going on. So in general, when there is damage or degeneration of the lower motor neuron, the things you're going to see, the main symptoms are going to be muscle weakness and muscle atrophy. So those lower motor neurons are no longer sending signals, or they're sending weak signals to the muscle, so the muscle will begin to waste away. That's what atrophy is. And so you will have weakness associated with that. You may also get something called fasciculations, which are muscle twitches. And I'll show you a video of what that looks like. So those are the main symptoms that you see with lower motor neuron disorders. With upper motor neuron disorders, when those upper motor neurons are no longer, I'm going to try and talk this afternoon. When those upper motor neurons are no longer sending signals down to the brainstem and spinal cord, the result that you typically see in the muscle is spasticity. So instead of weakness or flaccidity, like in the lower motor neurons, you tend to get a pattern of spasticity and hyperreflexia, so exaggerated reflex responses. Again, that's with upper motor neuron disorders. So if we look at this table, it outlines these things for us to help us distinguish. So for reflexes, upper motor neuron disorder, hyperreflexia, exaggerated reflex responses. Lower motor neuron disorder, we may have hyporeflexia, meaning an under-responsivity. Again, if you're tapping that tendon and that lower motor neuron can't fire, even if the sensory neuron's firing, you're going to get a diminished response, a diminished reflex. When we look at muscle tone, again, upper motor neuron disorder, we're more likely to have spasticity or increased tone. In lower motor neuron disorders, we're more likely to have flaccidity or a weakening, decreased muscle tone. I said I was going to show you fasciculations. Fasciculations are present with lower motor neuron disorders, not with upper motor neuron disorders. And so this is an example of fasciculations, I believe in ALS. Okay, so involuntary muscle contractions, again, that's an issue with the lower motor neuron. Atrophy of the muscle is going to be severe with lower motor neuron disorders, not necessarily with upper motor neuron disorders. And the Babinski sign, which I will show you as a reflex response, will be present in upper motor neuron disorders and absent in lower motor neuron disorders.
So the fasciculation is a clinical test, but did you say that you do something to make that happen, or you're just...
No, they're involuntary, so you would just observe. You don't do anything to facilitate it. And with most of these, except for the reflexes, which are the Babinski and other types of reflexes, these are things you would just observe in the muscles. So the Babinski something we may or may not have done in bees. I can't remember honestly. This guy's going to walk you through. You would not expect to see it in adults. So you would expect to see it in children up to about 12 months of age, I believe. You would not expect to see it in a typical adult. And you are going to test this on each other next week. Heads up, take a shower, wash your feet, put on clean socks. Okay? Yeah, I can hear the excitement.
Saying that upper motor neuron dysfunction, as is the case with this patient, the patient suffered a left side, a stroke affecting the left side of the brain. The stimulus is applied to the lateral aspect of the foot and then across the balls of the toes. The Babinski response, if present, the great toe will flex and the small toes will fan out. Exactly what happened here. One more time. And we say the Babinski's response is present. Compare that with the normal sign. A similar stimulus is applied, lateral aspect of the foot and across the toes. And the great toes and the small toes flex. Extend that down. So again, lateral stimulus across the balls of the toes. The toes go down.
So going down is fine, that's normal, but fanning out with the flexion of the big toe is atypical, and that's what you would see in an upper motor neuron disorder, not in a lower motor neuron disorder. So we'll talk about ALS for a minute.
Okay, we're going to show you now the Babinski reflex, and this is a reflex of the foot
Sorry
and of
about
the
that.
toes more
You
specifically.
want to watch it again? Apparently they just keep going. Okay. All right, so ALS is I said we were going to talk about some disorders that affect both the upper and lower motor neurons. ALS is one of those disorders. So ALS is a condition that usually affects people between the ages of 40 and 70. About 20,000 people in the U.S. at any given time have ALS. And the primary signs, or the first signs that you see, are muscle weakness and atrophy. So that tells you that there is a degeneration of what type of motor neurons? Lower. So muscle weakness and atrophy. Eventually, this disease will progress so that all voluntary movement is lost. So swallowing, locomotion, breathing, all is lost. So the loss of voluntary movement is going to be more indicative of what motor neuron problems? Upper. So that the voluntary controlled movement is reflective more of the upper motor neuron problems. And this progression to not being able to breathe usually happens anywhere between 1 and 5 years from the time of diagnosis. So from the time of diagnosis, the life expectancy for ALS is about 5 years at best. And this is considered mainly a lower motor neuron disorder. It mainly affects the cells in the ventral horn of the spinal cord. So what we see is muscle weakness, fasciculations, impaired bowel and bladder function, but it also does affect the upper motor neurons in the cortex, and so you will see that eventual loss of voluntary muscle control. It does not affect any other neurons in the cortex, so cognition, emotional control, all of that stuff remains completely intact, but the ability to control movement, the ability to initiate movement is diminished. The cause of ALS is unknown. 15 different genetic mutations have been identified. So it's actually considered not just one disorder, but potentially a collection of disorders that have the same symptom presentation. And the one commonality, or at least one thing that almost everybody with ALS demonstrates, is what's called excitotoxicity. And what this is that there's too much glutamate, which is a neurotransmitter. It's an excitatory neurotransmitter. There's too much glutamate being released into the synapses where these alpha motor neurons are. Sorry, not just alpha motor neurons, the upper and lower motor neurons. There's too much glutamate in the system. And glutamate is kind of like you guys on cocaine, okay? It excites, okay? And it makes the neurons fire, okay? And eventually, It's just they get too excited and they die. All right, that's what excitotoxicity is. All right, I don't have a better example. So that is a common factor: is too much glutamate, too much excitement. These motor neurons die off and they can't do their job. And so you would think with ALS that if you gave people with ALS glutamate blockers to reduce that glutamate, that would work. And unfortunately, it doesn't. What we see is that glutamate drugs, glutamate blockers can reduce the symptoms or delay the symptom progression for about 1 to 3 months. It can give them some relief, but eventually they stop working and the end result is the same. So treatments right now are mainly involving stem cells, trying to see if you can grow new motor neurons after certain motor neurons have died, and also looking at genetic vectors, so going in and trying to change or turn off those genetic mutations to stop this from happening. And most of that work is being done, at least with the viral vectors, in animal models. I don't know of any being done in humans at this point. So right now there is no cure for this disorder. Let me get Lars off the back up.
Since the type 2B muscles are glutamate intensive, does it affect those first?
The glutamate is affecting the cell bodies. So when we talked about 2B muscle fibers, that's at the level of the neuromuscular junction, and that's using acetylcholine. So we're talking about back in the ventral horn of the spinal cord or back up in the motor cortex. Those cell bodies are getting overly excited.
Is there any, I don't know if you would know if there's any research to indicate that there is excitotoxicity prior to even being diagnosed, of years prior?
That is a good question, and I don't know the answer to that. Like how early that excitotoxicity can be identified, I don't know. Okay, I wanted to show you this quick video on ALS. Sorry, this is a ad. I didn't even know what that was. But this gives you an idea of what it looks
First
like.
thing
and
everybody
it's really
asks is, how are you
powerful.
doing? You know, like, you can say fine, but like, there's a lot more to it than that.
It's a bigger question than just
Yeah,
how are
I
you doing?
mean, the first question is, how are you doing? Fine. And the second question is, how are you really doing? And that's a much longer conversation.
It's weird because it seems like it's like a whole different person.
It was only 6 months ago.
Yeah, it wasn't that long ago.
When you see yourself 6 months ago talking about ALS and about your friends, about how you're dealing with it, what are you thinking when you see that now?
I think how lucky that guy was at the time.
How do we end up sitting here with video cameras and microphones set up and
I mean, we've talked for a while about making a video. I want people to know what it's like and the good and the bad. You know, why is this 20 young looking person being rolled around in a wheelchair? It's a lot of questions in people's heads that they don't want to ask.
How long has it been since you were diagnosed?
It feels like it's been forever, but it really hasn't been that long. A little over 2.5 years since I've been diagnosed. And I've had symptoms for probably 4.
Until all of a sudden you notice you can't do something anymore that you could do 2 months ago. It's kind of like that. It's like bigger steps. Like I walked down my parents' driveway a month ago. I tried to do it yesterday and I couldn't do it.
Having watched the video we made, what's missing from that video in your story?
I think it's kind of sugar-coated a little bit. I mean, I don't think it really gets across what this disease will do to you. And I think at the time I didn't really know either. You know, there's been a lot of really drastic changes over the past 9 months. To eat, to go to the bathroom, to brush my teeth, absolutely anything I can't do on my own anymore. The most thing that's noticed is my voice is a lot different. It keeps getting worse. And now, you know, the ability to communicate is being threatened. And that's really scary.
So, from an OT perspective, when you are working with people that have ALS, and again, he is relatively young to be diagnosed, your intervention is not going to be really to try and strengthen those muscles or try and regain function. You may try to keep function as long as possible. A lot of what we're going to do is help them plan for what's coming next, because you can see how quickly function can be lost. So a lot of assistive technology, a lot of adaptive equipment, a lot of looking at safety and mobility, and again, maintaining as much independence as possible for as long as possible. We had a doctoral student here a while ago who works at Johns Hopkins University or University Hospital, and she set up an AT lending library. She got a grant from the ALS Foundation because they go through the technology so fast. So if they're spending all this money for this one thing, it may only work for them for a couple of months before they need something more intensive or something that requires less movement. So they set up a lending library so people with ALS can come in and get what they need and then return it when they can't use it anymore. So I think that's mainly going to be the focus of intervention, is to, again, maintain that function using AT, using adaptive equipment as long as possible, and then helping with positioning so that you're not getting skin breakdown, so that you're not getting secondary effects of that lack of mobility. Similar to ALS, there's a disorder called progressive bulbar palsy, and you won't want to get this confused with pseudobulbar palsy, which we'll talk about next week. Progressive bulbar palsy is really similar to ALS in that it targets the lower motor neurons, but in the brainstem. It's called bulbar palsy because when they first used to look at the brainstem, this looked like a bulb. Right? So the bulbar palsy relates to the nerves, cranial nerves, coming out, the cranial motor nerves coming out at the level of the brainstem. And these are mainly the muscles that control the jaw, the face, the tongue, the palate, the larynx, muscles of facial expression. So what are we talking about? Which cranial nerves are doing that? Facial is 7, so that's going to be muscles of facial expression. What else? 12. Okay, so 12, hypoglossal, shape of tongue. Glossopharyngeal is going to be elevating the larynx and helping with swallowing. Vagus is going to be assisting with swallowing and things related to voice resonance. And trigeminal is the one that I didn't hear, and that's going to be muscles of mastication, so chewing. So these motor neurons, again, coming off of the brainstem, the lower motor neurons are affected, and what you see, as you would expect to see with lower motor neuron disorder, is weakness and atrophy. And one of the key signs of progressive bulbar palsy is atrophy of the tongue. And you can see it in this picture, just a degeneration of the muscles of the tongue. There's a progressive loss of speech along with a progressive difficulty with swallowing. And this puts people with this disorder at risk for choking and aspiration pneumonia if they can't swallow and the food gets stuck, or the food is, during swallowing, food is slipping down and going into the airway, and that would lead to aspiration pneumonia. So those are the major concerns for people with this disorder, and usually what leads to sickness and death. It's, again, similar to ALS, and it's actually thought possibly that this is a subtype of ALS. because people with ALS, eventually the lower motor neurons in the brainstem are also affected. And so there's, again, a similarity and an overlap here. In addition to tongue atrophy, the voice quality becomes sort of nasally because of the escape of air through the nose. And you can kind of hear that in the video as well, the gentleman who had ALS, that as his disease progressed, his voice changed and it not only became more breathy, but it became more nasally as well. So those are the things that you would look for in that condition. Another lower motor neuron disorder is spinal muscular atrophy. How many of you guys have heard of this one? It's not that common, so yeah, if you've heard of it or if you've seen it. This is another genetic disorder, and what happens is there's a dysfunction in the gene regulation that makes the protein SMN, which stands for survival motor neuron. So as you can expect, if you don't have enough of this protein, your motor neurons do not survive and they start to die off. And again, this is specific to lower motor neurons. And the muscles that are affected are muscles that are more proximal or closer to the center of the body, not necessarily just the trunk muscles, but we see it in the proximal lower and upper extremities, as well as muscles that control respiration. And so that is the main source of death in this disorder is respiratory failures, when the muscles of the respiratory system stop working. And there's 3 types of this, and you don't need to know the difference between all 3 types, but the types are based on age and severity. And the younger you are diagnosed, the worse your symptoms are and the lower your life expectancy. So again, the younger you're diagnosed, the worse your symptoms are and the shorter your life expectancy. And so type 1 infants are diagnosed before age 6 months. Symptoms appear before 6 months of age. These infants never learn to sit up. They're very hypotonic, very, very low tone. They really don't gain a lot of independent mobility. They tend to have a lot of respiratory distress and tend to die before 2 years of age because of those respiratory problems. Type 2 is sometimes called the intermediate type. It's diagnosed in kids between 6 months and 2 years of age. These kids may be able to sit up by themselves. So I'm thinking this kid, I don't know anything about him, but in this picture, he's got some trunk control and may be able to sit up on his own, but these kids don't ever ambulate independently or move independently. They can have respiratory failure, but in general they can live, their life expectancy is shortened, but generally they will live into adolescence, maybe even young adulthood. With the low muscle tone, you may have problems with scoliosis or other types of joint contractures because, again, they can't independently move all of the parts of their body. Anna?
So is this like ALS in the sense that it gets progressively worse, or is it that they're born with this weakness and then it just, the diagnosis time varies because it's so rare that they have a hard time like figuring out what it is?
No, with all of these there is a progressive worsening.
Okay.
Yeah. And I say that, and then the third type is a type that's diagnosed later, usually between, I guess, 2 years of age and even into the teenage years. And with that, it's you can have a normal life expectancy. There are a lot of complications associated with it, but the progression is slow enough that you don't necessarily have the respiratory problems, and therefore you don't have respiratory failure. So with the type 3, again, with an older child being diagnosed or the symptoms appearing later, they may be independently mobile. They'll probably have some gait issues. They probably will have some coordination issues. They may have scoliosis or other joint deformities because of the low muscle tone and the weakness. But without the respiratory failure, you may have a normal lifespan. And again, just like with ALS, sensory, cognitive, emotional functioning are completely normal in these kids. All right, one more motor neuron disorder, and that is polio and post-polio syndrome. So polio itself is a virus that attacks cells in the ventral horn of the spinal cord, so it's attacking our lower motor neurons. And when that happens, picture for a second, if this is a normal alpha motor neuron coming to innervate extrafusal muscle, we've got two different motor units here. In polio, it attacks those cells in the ventral horn, causing some of those alpha motor neurons to die. So you have remaining alpha motor neurons. In this case, one of the two has died. What will happen, again, this is still polio, is that remaining axon, that remaining alpha motor neuron will sprout collateral branches. So these are called axonal sprouts that come off that original axon to try and compensate for that loss. And so this is a normal part of recovery in polio. This is how you get recovery in polio, is that those original alpha motor neurons, their cell body dies, they die. But you can get regained function because of this axonal sprouting. What happens in post-polio syndrome is that 30 to 40 years after this sprouting has occurred, this alpha motor neuron is tired. It has been doing the job of 2 or 3 or 10 other alpha motor neurons for 40 years, and it essentially gives out. It gets tired, these sprouts die. The axon, or the original alpha motor neuron, doesn't necessarily die, but these sprouts degenerate, leaving you with muscle weakness in muscles that were previously affected, and sometimes even new muscles. But generally, it's re-weakening of the muscles that were originally affected by the polio virus. And you can get associated muscle pain and fatigue with that muscle weakness. And sometimes what will happen is, so again, if you lose these sprouts, you're back to this, okay? Sometimes other alpha motor neurons will come in and you'll get more sprouting. And so you'll get sort of a rejuvenation, a reawakening of those muscles, a reinnervation of those muscles. But again, the same process can happen again, that those axons become overworked and overused, and you can have a re-weakening of those muscles. So sometimes post-polio syndrome, you get this initial, bam, this is happening, and then it can be cyclical, or it can come and go in terms of as those muscles weaken. But it becomes progressive to where there's no compensation anymore, and you just have muscle weakness. And this isn't something that we typically see in the U.S. because we have been polio-free for many, many years. I'm not sure, how many of you guys have ever met somebody with post-polio syndrome? A couple of you. Was it recent?
Well, it's funny, I wrote the paper last semester for MedVax for post-polio
Okay.
syndrome, and then the lady in my fieldwork this last week had post-polio syndrome.
How old was she?
She was like in her mid-70s.
70s. So I was going to guess, because the last person I knew that had it was about 20 years ago, and she was 50 then. So I was thinking like this last generation of polio survivors is probably in their 70s or 80s now. Others of you guys that have seen people with post-polio?
It was similar. He was probably in the 70s, and it was back in the day when they didn't have to get
The vaccine.
vaccination for it.
Yeah. So, yeah.
And then does everyone that have polio get post-polio syndrome?
I would assume yes, but I don't know the exact
Because I
answer
know
to
someone
that.
that had polio.
But I don't know if it was in an adult day center. So.
It would probably depend on how bad the virus was initially and how much weakness and loss she had initially. But if there was a significant loss and then a recovery, my guess is she is very susceptible to post-polio syndrome and having this re-weakening of the muscles occur. So again, you may come across this then in your fieldwork. We're talking about people in their 70s and their 80s, and you're working with an adult population. It may be something that you see. And if any of you guys go to work in developing countries, you may still see polio. Some countries, we go to Ghana, and they say that polio has been eradicated for years, and we go there and we see kids that certainly look like they have polio. So you don't know, it's worth knowing about. Okay, so we'll talk a minute about muscle tone. This is a term you're familiar with. So muscle tone, when we talk about it neurologically, is a sustained contraction of muscle fibers, even when that muscle is at rest. And what that means is that some motor units are always active, even when, again, you're not trying to contract that muscle. And the purpose is that you need your muscles to maintain a certain level of tension to maintain joint stability, to keep your body in a position against gravity so you're not falling completely at the mercy of gravity all the time. And these motor units alternate. So again, they're not, some of them are always working, but they're not always working at the same time to maintain muscle tone. So they alternate activity. And that how active they are depends partially on signals from what system? Vestibular system. So the vestibular system sends those descending signals down the spinal cord and tells these lower motor neurons, hey, this is the force of gravity, this is what's happening right now, this is how active you all need to be. And again, muscle tone helps with joint stability, it helps keep the muscle tension that we need for posture and body position and balance, and it helps us to control our motor movements or prevent sudden uncontrolled changes in position. And we really talk about muscle tone the most when we see it being atypical. And in kids in particular, we see a condition called hypotonia or low muscle tone, clinically significant low muscle tone. So some of you may have low muscle tone. Whether or not you would fit the classification of hypotonia, there's not like an official line or marker for hypotonia. It can occur in kids that have disorders, so children with Down syndrome. Some children with certain types of cerebral palsy have hypotonia. And you're used to thinking of CP as spasticity, but some types of CP have low tone or flaccidity. Other types of genetic disorders are more likely to elicit hypotonia or low muscle tone. You can also have hypotonia in the absence of any disorder, and this is called benign congenital hypotonia, just meaning you're born with it, there's nothing else wrong with you, you have low muscle tone. And the reason low muscle tone is bad, or not optimal, let's say, is because, again, we can't maintain that posture against gravity. And this can lead to problems or associated hypermobility of joints. It can also lead to tightening in muscles and weakening of muscles, depending on what muscle groups are being used or what muscle groups are being overused. So if we look at this kiddo and sitting on this stool, we can see a posterior pelvic tilt. Okay, so again, if these ab muscles aren't working, which they're not, then your tendency is going to be to slump back. Can you guys go into a posterior pelvic tilt? Yes. You guys can do it. Alright? Alright, so your abs aren't doing anything. You're just kind of sitting, kind of tilting back and leaning. And then to look up at the board, look what has to happen. You have to hyperextend at your neck to be able to see up. And you guys can fix your position, and in this example, he's also gaining stability with a wide base of support at the legs and pressing off and trying to get some input through his feet. So the end result of this position for a long period of time is going to be a weakening of the abdominals because they're not being used on a regular basis. It's going to be probably hypermobility in some of the cervical vertebrae because you're constantly hyperextending them. You're probably going to have some reduced joint mobility in the thoracic vertebrae because you're not moving them at all. And you're going to have tightening of the heel cords because you've got your feet in this dorsiflexed position and tightening of the calves and, again, the heel cords. So low tone in and of itself isn't all that problematic, but over time it leads to these atypical biomechanical types of issues. And functionally, in kids, we see problems with head control. We see that the head isn't stable, so the eyes don't have a really good base to move off of. Because you don't have that good proximal stability, you're not going to have great distal control. Go back into that posterior pelvic tilt and now try writing. All right, you guys have enough compensation, but it usually puts your arm in a funky position. It makes writing a little bit harder if you're slumped down like this. For some kids that have low muscle tone through the face, you may see speech and articulation issues. You can also see feeding and swallowing problems. In kids with Down syndrome that have pretty severe low muscle tone, or they can, you see that open mouth posture, all right? And you can have drooling and other types of things that are related to, again, the low muscle tone. So, whoops, let me go back for a second. Different theories on how to intervene. Can we intervene for low muscle tone? In SI theory, we are going to target, if we're using that frame of reference, one of the things that we may try and do is use vestibular system, use high intensity vestibular input to try and activate those lower motor neurons and to get more extension, to get more activity, to elicit greater muscle tone. Like swinging, yeah. Swinging, jumping. So we can talk about linear or rotational input to try and facilitate that extension against gravity. Now the effects of that are probably going to be fairly short-lived, so they need to be followed by functional activities and possibly strengthening. So a biomechanical approach is going to say we're going to strengthen the weak muscles. I'm going to strengthen the abdominals. I'm going to strengthen these proximal muscles on the back that aren't really doing a whole lot. And I'm going to stretch and try and get full mobility back in those tight muscles, like the heel cords or the thoracic vertebrae. If you're taking a top-down, I'm not a good theory person, but like moho or something, okay? You're going to look at the volitional, motivational aspects of the child and work on the functional tasks that they're having problems with, and maybe not worry about the low muscle tone at all, but practice shoe tying, or look at other types of skills that they need to be able to do and how you can adapt the chair, let's say, to make the environment more susceptible to their motor control, or adapt their tools so that it can help with the stool control. So in terms of treatment for low muscle tone, there's different approaches that we can take, kind of depending on the theory that you use, and oftentimes we use all of them, or we use any one of them at different periods of time. But that's kind of where we start to integrate theory with, neuro with treatment. We'll talk for a minute about strengthening. So I mentioned that as a biomechanical intervention. We talked about muscle fibers today. We know that we are capable of getting stronger, but what does stronger mean? Stronger really means two things. Two processes underlie our ability to gain muscle strength. And one, the Arnold Schwarzenegger approach up here, is hypertrophy. So enlargement of the actual muscle fibers. So that if we do resistive exercises, if we consistently activate or generate force in those type 2B muscle fibers, they can get bigger. And they can get bigger through a variety of ways that you don't necessarily need to know, but they can have more connective tissue, they can have more just nutrients packed into them, they can have more proteins within them. But the principle is that the fibers themselves can get bigger. It's one way that we strengthen muscle. The other way is that we can enhance that innervation, and enhance the innervation of that muscle. So we don't grow new cell bodies. We don't grow new lower motor neurons in the ventral horn, but like we saw in the polio example, we can sprout axons, and so we can get more innervation to individual muscle fibers. And we talked about in the beginning with those motor units, the more action potentials that are firing, the more force we can generate. So that there was that rate code principle, right? So by having more innervation to the muscle fibers, we're going to be generating more action potentials and being able to get a higher level of force when we contract. And so sometimes people can be stronger without necessarily being bigger. And that would be the rationale for why that's the case. And there's two types of exercises, I should probably put in two types, two main ways that we classify strengthening. And those are isometric and isotonic contractions. And not being a really good muscle physiologist, I'm going to let this tutorial walk you through those two different types.
Did you know that your muscles are contracting even when you're trying to rest? Skeletal muscles are contractile organs composed of several motor units.
Some of this will be review.
A motor unit includes all the muscle fibers innervated by a single motor neuron. and at least some motor units are always contracting, again, even when we're at rest. The contraction may not be enough to produce movement, but they keep the muscle at a resting level of tension or tone. Okay, so what's muscle tone? Muscle tone is the resting tension in the skeletal muscle, and it helps to stabilize the position of the bones in the joints. This lesson will describe the nature of isometric contractions, in which the muscle does not change length, and isotonic contraction, in which the muscle length changes without additional tension or force development. Isotonic literally means same tension, where iso means the same and tonic refers to tension or force, in this case in the muscle. In an isotonic contraction, tension develops to a point and then remains constant while the muscle changes its length. In other words, motor units are activated to develop the necessary tension in the muscle. We utilize isotonic contractions when we move our limbs. Now let's consider an example. Let's consider a man attempting to curl 25 kilograms. This movement requires the use of the biceps brachii, also known as our guns. Now, before the muscle can shorten and thus move the 25 kilogram load, it must first develop slightly more than 25 kilograms of tension. Now, once enough motor units are activated to produce tension slightly greater than the load, the muscle can then shorten. Now, if you try this yourself, you will notice tension developing in your muscle even before you move your weight. Once muscle tension slightly exceeds the load, muscular contraction can then be used to shorten the muscle and move the load.
What order are those muscle fibers being recruited in? What comes first? Type 1s, then 2As, then 2Bs. Okay, so that initial, I got to get the force going, that's showing you that progression before those 2Bs are recruited, and you can generate that burst force to get that up.
It's important to note that force does not change in the muscle while it's shortening, hence the term isotonic contraction. It's also important to note that there are two types of isotonic contraction. Concentric contraction occurs when the muscle shortens, while eccentric contraction occurs when the muscle lengthens. Well, let me explain. Let's re-examine our weightlifter. The muscle shortens when the arm flexes at the elbow in the act of curling. Therefore, this is a concentric contraction. Does the muscle contract during extension while doing a curling exercise? Well, as it turns out, the answer is yes. You see, as the man extends his arm, that same muscle, the biceps brachii, now lengthens and maintains tension slightly greater than the load. In this case, slightly greater than 25 kilograms. This tension is maintained by eccentric contraction. Eccentric contraction helps to control the rate of movement. All right, let's move on to isometric contractions. Isometric literally means same length, where again iso means the same, and here metric refers to length. Now we're talking about the length of the muscle. During an isometric contraction, the muscle as a whole does not change its length, and the tension developed in the muscle never exceeds the load. This is what happens when we attempt to lift more than we can. Let's take a look at our weightlifter one more time. Let's imagine his attention is diverted by a person of interest walking by. While he's looking away, a mischievous friend replaces the 25 kilogram weight with a 50 kilogram weight. Now the weightlifter attempts to make an impression by curling the weight, not knowing that it has doubled in size. Well, much to his dismay, he's unable to move the weight. Why not? Simply put, he was not able to develop enough tension in the muscle to slightly exceed the load. In other words, 50 kilograms was too much. Even with all the motor units activated, he could not develop enough tension. Let's imagine that we could measure the tension developed in the muscle during this isometric contraction. As you can see on the screen, the tension increases to 40 kilograms and then remains constant the whole time your friend is trying to move the weight. As the muscle does not change its length, it is referred to an isometric contraction, and again, he can't curl the weight. Our daily activities utilize both isometric and isotonic contractions. For example, our postural muscles are undergoing isometric contractions to keep our head up, to keep your head up while you watch this lesson. Some of those same muscles undergo isotonic contraction in order to move your head to the left or to the right. In summary, skeletal muscle contractions are either isometric, in which the muscle does not change its length, or isotonic, in which the muscle changes its length without increasing tension.
Okay, so that is your quick and dirty on isometric and isotonic. And hopefully you've heard those terms before. Again, both of these are going to promote muscle strength depending on how you use them. And thinking about what you're doing in OT, there's a variety of activities that we do to work on muscle strength that are going to involve both isometric and isotonic type contractions. So if we're looking at kids and having this little girl paint on a vertical surface, we're asking her to hold and stabilize at the shoulder, so working on those postural muscles, which are going to be an isometric contraction. You're not changing the length necessarily of those muscles. As opposed to something like climbing against resistance, where there is force being generated, the muscle is changing length and generating force as they go up. And similarly, I don't know, with adults, I just think it looks so boring, but we use TheraBand, we use weights, we use canes to provide resistance in activities. We also may have people, so those are all isotonic, but we may also have them pushing and holding a position in their wheelchair if they can't do some of these other things. So again, as you're going through and you're learning about these in your intervention classes, you can think about what muscles are being strengthened, what principles are being used to strengthen them, what would we expect to see, where is the resistance, and what muscles are being activated. Caitlin?
Okay, so I have two questions.
Sure.
In that video, he made it seem like for isometric contractions that the load had to be greater than the tension that you're able to develop, but is that not always the case?
I think that it is, if you think about it more of just, there's no change in muscle. So if you're holding against a certain resistance and the muscle is not, so if you're doing a plank, right, and you're essentially trying to push into the ground when you're doing a plank. So that is your resistance. You can push as hard as you want to, but your arm is not going to go through that floor. So you're still pushing against a resistance, and it is causing you to not change the length of that muscle.
Okay.
So I think in most cases you're still coming up against a resistance, even if I'm just holding a position and resisting gravity.
But it doesn't have to be greater than the possible tension I can develop in my muscles. So like holding your head up, like, I may be able to do some, I don't know what kind of exercises you would do with your neck,
Right.
but like
You could go against
me
more
holding
resistance.
just my head up.
Correct. So yeah,
Okay.
I don't think it has to be maximal. You're maxing out force generation.
Okay, and then can I ask a
Yeah,
second
sure.
question? Okay, so the enhanced, when we're talking about increasing strength and you enhance muscle innervation so that you're sprouting axon so it has more, it's going to more muscle fibers, does that mean that it's gonna do, like we talked about, if it has more muscle fibers that it's innervating, then it's gonna be less precise? So do those muscles also get?
I think we tend to see hypertrophy in those larger diameter fibers and probably more proximal musculature, as opposed to, you don't really see it as much in the fingertips, let's say, even though you may see some changes. So probably it's going to be more related to those muscle units that aren't controlling precise movements.
That are not.
Yeah.
Okay.
Okay, last few things before we break, and we are at time. Just when we talk about control of movement, there's two principles. One is that motor control can be hierarchically organized, meaning higher centers controlling lower centers. We saw that an example today is just in upper motor neurons controlling lower motor neurons. But there's a parallel distribution where information related to motor control gets sent to a variety of different brain centers simultaneously and interact upon each other. And so I'm going to skip ahead. Those are explained here. If we look at, this is adapted from your book, so I would go ahead and take a look at that. That was in your readings for today. But higher level centers, the limbic system gives us motivation to act. Our association cortices give us information about the value. Remember we talked about taste and smell association cortices, the value of what we're going to do. How much do I want to move? What's the goal of my movement? That's what we're getting from higher level centers. Intermediate level centers like the basal ganglia, like our premotor cortex, like our cerebellum and motor cortex, they're going to help us develop a plan. And so even though the limbic system and the association cortices are going to project to these areas and give information about what we want to do, there's parallel processing in that information is getting sent to a variety of areas and resent back to kind of refine motor programs as we go. So information, it's not just step. There's distribution across different areas of the brain, and eventually hits our lower level centers, the brainstem and the spinal cord, to execute the motor movements in the periphery. And we'll talk about lateral cerebellum versus intermediate cerebellum in a couple of weeks. But that's the concept of hierarchy, is that there is higher to lower ordering of how motor commands are generated. But the parallel processing is the distribution of signals throughout different areas of the brain and the talking back and forth between those different levels. And last, motor learning. When we talk about motor learning, we're talking about aspects of how we learn new motor patterns. I will talk about this more next week, but this is really, if you remember that theory, is how do we get better with practice? How does practice and experience influence our ability to become more automatic in our movements and to have to think about what we do less? And most of our first half of the semester was spent here in sensation and perception. A good part of our day today was talking about muscles and motor neurons and the action part. Really, the next couple weeks is going to be spent here, looking at higher level centers and control of movement. So this is just a platform for sort of where we've been and where we're going for the next 4 weeks, okay? So 3 weeks after today. Whew, I have 6 more lectures left. I'm counting down. All right, I'm sorry. Tell Carol I'm sorry you guys are a few minutes late. Mea culpa, and I will see you guys next week.